I'd like to begin with some questions, if I could, specifically to Dr. DeSantis. At this point, I want you to tell us a little bit about some of the differences that you've noticed. You work in a busy emergency department at Robert Wood Johnson, and others in the room have also been directly involved in emergency medicine. How much more severe were the wounds of war than what you see here in civilian settings?
You know, obviously not every patient in Iraq that comes into the shock trauma platoon is a massive amputee traumatic patient. But one of the things, though, that really big contrast, it took me probably about a month to get accustomed to, is the luxury of working in a level 1 trauma center. CAT scans, x-rays, consultants all over the place, oxygen all over the place. And one of the things that we don't have is CT scans up front in war. And so what we do to identify traumatic brain injury, because even mild traumatic brain injury can be associated with post-traumatic stress, is we go ahead out and do what's called a military acute concussion evaluation. Within 24 hours, having been exposed to a bomb blast, we approach that patient and we do this MACE scoring. And depending upon how they score on that MACE scoring, we'll recommend that person to be flown for a CAT scan. We'll recommend that person to go out and receive potentially psychiatric treatment in combat. Or we'll ask the person to take a seat out, much like you do in sports injuries. When an athlete is playing football or hockey and they receive a head injury, you'll ask that athlete potentially take a seat out or take a week off from a game. We're doing these assessments out there, recognizing these mild traumatic brain injuries and asking folks to take a seat back in combat.
Thank you. To both doctors, about advances in medical care that you've seen in the combat zone, one thing we keep hearing about is speed, that the wounded are being sent more quickly to health teams, and that can help them the most. How does that work in more detail, if you would, and how does it save lives? The question's for both of you.
We've actually kind of changed the way that we take care of the acutely injured. There are several levels of care within the combat zone, and much like Frank said, I've trained and worked at a level 1 trauma center. You have everything at your hands there. When you're in a shock trauma platoon or a FRIS, a forward resuscitation surgical system, or a combat support hospital, those type of things that are on the front lines, your job is really not to do a lot of definitive operations and definitive care. Your job is to stabilize those patients. So from the field where perhaps combat tourniquets have been placed, IVs have been started by your corpsman, the patients are rushed to the first line of care, which is your shock trauma platoon and your subsequent surgical site. Those patients at those areas are then stabilized. Tubes are placed, larger bore IVs are started, perhaps blood products, definitive surgical procedures such as stopping bleeding, controlling contamination, that type of stuff is done there. And that's it. Our job in these forward areas is to stabilize the patients and then move them on to the next level of care, which is where more definitive procedures are done. Everything that we've done is looked at a second time, make sure there weren't any injuries that were missed. As Dr. DeSantos said, we're working with very rudimentary, and I don't mean that in a bad way, it's just what you can have in a forward area, maybe some digital x-rays and ultrasound, and that's about it in terms of your radiology. At your next level of care, your level 3s, they have CAT scan, they have specialty consultants, etc., and patients will receive more definitive care, and then from there, once they're stabilized at that level, then they go to launch stool, where again, more evaluations, more surgeries, etc., and then ultimately back to the States. So it's a gradation of care that's basically, in my opinion, saving lives, because we're not trying to do everything at the first stop. I think a lot of times you can get into lethal situations where the patient's lost a lot of blood and we continue to operate and try to stop more bleeding and try to stop more bleeding. That you start running down a rabbit hole where you can actually do more damage. So a gradation of care to the injured is probably something that we've learned from this conflict that is really working and really saving lives.
You know, it's funny, I lived in Italy for 3 years with the Navy, and I was a Formula One fan while I was there. And I always compare battlefield medicine similar to the pit stops in Formula One. I mean, the driver comes on in, load them up with gas, tires, and and get them going, kind of quick, fast, and keep it going. And I think combat medicine is very much that way. We've learned to become that way. As we go forward, we go lighter and we're quicker, so that as a patient comes on in, sort of like Sergeant Nuzio, you take care of what you need to take care of in that combat environment and get him out of there back to the States as soon as possible in the safest manner, as fast as possible. So we don't want to take all our level 1 trauma centers to the battlefield. We want to take the patient back to the level 1 trauma center back at home and do those quick pit stops out in battlefield.
A term that has been created in combat as well as in civilian trauma management is damage control. Right. And that's been popular, and it's now given a term damage control resuscitation. Would you explain to our audience what that's all about?
Damage control resuscitation is starting lines, intravenous lines, resuscitating the patient in terms of their intravascular volume, blood products, injuries that occur where individuals have extremities that are mangled, blown off, and I don't mean any disrespect by that. Not only have they lost a limb, but they've lost a tremendous amount of blood into the environment. And so we'll start blood products as quickly as possible and resuscitate the patient from a volume status, placing chest tubes, and if they need to go to the operating room, the damage control surgeries are, the term that they used to use in MASH was meatball surgery, where you're really doing, I don't mean this in a bad way either, you're doing gross things in terms of ligating vessels, perhaps shunting major vessels where you need to keep an extremity perfused because the main artery going into it has been damaged or severed. You do things to stabilize the patient and to stop massive bleeding and massive contamination. When I came back from my tour this time, somebody said to me, "Oh, I guess you got a chance to do a lot of vascular surgery and a lot of intricate stuff." And I said, as a matter of fact, I didn't. I did a lot of damage control surgery. There's nothing particularly finesse about it. It's stopping bleeding, controlling the contamination, stabilizing the patient, and moving them on to the next level of care where more definitive stuff can be done. And that's what we do in these forward operating areas.
Captain, I got to interject. Now, there's a lot of Navy personnel here. Is there a damage control officer in this process, and where did that term come from?
Army.
Usually, it'll be, at least where we were, it was a combined effort between our emergency room physicians and our surgeons in terms of what needs to be done with the patient here and now. And, does the patient need to go back to the operating room? Can we control it in the shock trauma platoon? And usually, whoever happened to be on call that day was running the show. We had our senior medical officers and our senior and our chief surgeon, whoever was the officer on that day, and it was usually a collaborative effort, which I have to say I thought was terrific. Sometimes ER and surgeons can bang heads. I think we had a pretty good team where we were.
Dr. DeSantos, you talked about the ways that lives are being saved, and that's the good news. The bad news is that the person who survives may have his or her life altered forever in ways that we didn't see in past wars. I know you saw leg amputations that fit that category, where body armor saved a life, but the result was terrible. Can you talk about that a little bit for us?
If you look at the history of conflict from the time of the Revolutionary War till the present conflict in Iraq and Afghanistan, mortality has gone down from 42% down to 10%. And like I mentioned before, part of that is logistics, but if you look at a picture of a U.S. military member in combat, they've got Kevlar on their head, they've got flak all over their chest and their back and covering part of their abdomen. So the injuries that they're receiving are mostly extremity injuries. And these extremity injuries are obviously quite grotesque. In the past, there's a subset of patients that would pass away if we didn't get to them, if we didn't resuscitate them within what was called this golden hour of trauma, within 1 hour. And what we found out, though, is that with these severe extremity injuries, that if we get in there within within 60 minutes and do this damage control what Dr. Swan was talking about, we're saving these lives. That's the good news. The bad news is they're coming back home as amputees with obviously post-traumatic stress and having to transition back into the U.S. And there are great programs, much like this here at UMDNJ, they're assisting that are providing a great benefit. But at the same time, you have to see, and Joe and I were talking about this before we came out here, the majority of the patients we saw were Iraqis, were the enemy. And they don't have flak, they don't have Kevlar, and there is a significant difference between those patients' survival rates and our patients in terms of survival.
Joe, could you comment from being at Walter Reed during the time that you were and mentioning being amongst those soldiers who survived those wounds? Anything you're comfortable sharing?
Words can't express some of the injuries that these guys and girls are receiving. I remember right now one of the secretaries of the Department of Veterans Affairs, her name's Tammy Duckworth, she's an assistant there now, and she was a Black Hawk pilot, and she got injured the same time I was, and I was at Walter Reed the same time, and RPG took down her Black Hawk, and she lost both her legs and one of her arm, and she now works for the Department of Veterans Affairs, you know, real successful lady. And until you actually see a person, you know, straight off the battlefield, and I remember waiting in the operating room, the prep rooms, you know, and in 2004 there was a lot of action going on at Walter Reed, and guys are, you know, there was 20 of us maybe in the room getting ready to roll out of that room into an OR. And, you know, these guys are, this is my 10th straight surgery. I just got off, you know, dirt in their hair, still dirt on their face. You know, I haven't even gotten cleaned up yet. And they're going in for their 5th or 6th or 7th surgery in a row just to clean gunshot wounds out or whatever is wrong with it. But it's terrible, some of the injuries. And it's the technology. These guys are staying alive and they're being saved, you know, with the medical advancements that we have, and they say that in every war, you know, from war, you know, there's medical advancements, technology that comes out of every war. So, but, you know, the injuries that these guys are living with are terrible, and you can't even understand some of the pain every day these guys are in. You know, the double amputees, and it's tough. And like I was saying before in my introduction, that was hard living with these guys, you know, eating in the cafeteria, you know, carrying their trays, and I feel lucky. You know, I lost an eye, and I'm thank God every day that I'm here, and this is all that happened to me, because there's some terrible things, you know, that happened to these guys out there.
Audrey, can you share a little bit more with us about your experience in transporting these soldiers and what went on the flights?
Prior to my deployment, I was one of the nurses that would fly from Andrews Air Force Base to Germany to pick up the injured. And that's when we actually saw our most amount of casualties. We would have 60, 70 patients, and you never knew what aircraft you were going to fly in. You would get to Andrews and you may fly in a C-17 or a 141. So once you got there, it was kind of interesting to figure out what you were going to do. Because if I was flying in a 141, I had to get it in a different mindset, because our patients would come back from Germany stacked 4 with a 5th litter on top, and being 5'2", I'd have to climb to care for them. So you had to get in your mindset. You had to find out what your patient load was going out, and then when you would get out there, it may change. So when I was deployed to Iraq, I thought it would be the same. When I was deployed to Germany and flying in and out of Iraq, I thought it would be the same, but it was quite different. You'd be on alert and be a few minutes into alert, told you were going out to Iraq to pick up 5 or 6 patients. So you'd set up your aircraft. Once you got to find out what aircraft, you'd set up your aircraft. You'd go midway between. You'd get a message that there's now 30 patients. So you have to reconfigure, which isn't a big deal because you have plenty of time. But then you would land, and depending on what was going on and where you were landing, you'd be given a time frame of how much time you had to get the patients on the aircraft. I would say 8 out of 10 times once we landed, our aircraft configuration changed because the patient manifest would change. And again, that was because, you know, while we were busy flying, the field docs and nurses were caring for patients, and things were changing to get them out as quick as possible. So you would adjust, you would land, and you would, as soon as you get there, you don't have time to say, well, I'm just going to go talk to the doc, let me see what's going on. The minute you land, things are moving. They're coming in on the aircraft, you're speaking with the flight nurses, and remember, most of the time there's no doc. So once they get in that aircraft and we take off, we are the ones providing the utmost care for them. So you have to really know your nursing skills, be cognizant of the types of wounds, and not just wounds, but also the stresses of flight. People don't realize if you've flown in an aircraft every day, you know how you get fatigued after you've flown a long time. They talk about blood clots in your legs. Well, these soldiers are flying for 5 or 6 hours in an aircraft that could be noise, vibration to their wounds, cold, depending on where you place them in the aircraft. So you have to be well prepared and thinking ahead what you need to ask the docs for before you take off. The biggest part of what we did was provide pain management. A lot of times these guys don't want to take drugs because they think their injuries, if they have a minor injury, they could be treated and get right back to the field. And then the significant injured patients, those soldiers who we were flying out with minor injuries would always come up to us because they saw how we were so busy, pushing IVs, giving drugs, providing care. And in an atmosphere where you can't talk to the patient, they all have earplugs in, you have earplugs in, so you're only reading lips. You can't hear monitors go off if a patient's pulse, their oxygen level goes down. You can't hear a monitor go off if their heart rate goes down or their heart rate goes up. So you have to be in tune to all that. The interesting thing for me was a lot of the soldiers who were coming back with minor injuries would always come up to us and say, how can I help? They would be willing to step up to the plate and say, what do I, just go hold his hand, think about what he's doing. And it also gave me an opportunity to talk to a lot of soldiers who had concerns about, I took care of a double amputee and he wasn't concerned about his legs. All he cared about was his friends, the 2 friends after the aircraft who had significant head injuries. What was their life going to be like? And for me, it was overwhelming to think, oh my God, you have a significant injury and you're caring about what's happening to your peers. So we provided a lot of care, and then again, if something went wrong, you had to think on your feet. We had patients that would go into a cardiac arrest in the air. You had to think about what you were going to do. We were able to reach docs, which were really nice, but you'd have to go through the front end or the pilots, which sometimes took a significant amount of time. So their care we were solely responsible, which is a big responsibility, but it was nice to know that most of our soldiers got back to Germany and were able to go on for a more definitive care.
Audrey, thank you very much. It sounds like you're talking about morale. Would you say that the morale and the team spirit amongst the healthcare givers in the combat zone exceeds that what you find on the home front?
Absolutely. Absolutely.
When
you work in a busy emergency room here, it's like, oh my God, I have 7 patients today. Oh, we only had 3 or 4. Come on, you get over there and work. But when you're on the aircraft, and my job on the aircraft, I'm a flight nurse, but I was always the MCD, which is the medical crew director, and I was responsible for all the patients, my crew. And just a little bit about nursing. We don't just have to know patient care. We have to know all the exits, how they open, oxygen equipment, electrical equipment, so that we can, if we have to crash, ground landing or ocean landing, how to get those patients out, what we need to do for them. So in the military setting, when you fly, I was the MCD. People would say, you do your paperwork. But how can I expect 2 nurses and 3 techs to care for 70 patients? So I always divided up where I wouldn't take the most critical, but I would take as many patients as I could. And then you would get home and you would think we would be exhausted, but we would go out and we would talk about all the interesting things that the soldiers taught us, not that what we had done. And I don't see that in as much in civilian.
I always felt the wounded warrior evoked the most dedicated team spirit I've ever experienced in healthcare delivery. And I don't know how the surgeons feel about that or the emergency medicine physicians feel about that.
Yeah, I think it certainly brings out the best in you. I mean, you really want to do everything you can for this person. What I thought was interesting is that, while Joe and I were there, we caught that surge, we're part of that surge opportunity that was put out during the Bush presidency. And we were exposed to Army individuals that were there for 15 months. And I remember seeing these folks out there and saying, God, you've been out here for 15 months. That's like I take my hat off to you. And they really still kept their motivation. And to me, when they said Army strong, that really rings home. 15 months out there does a lot to you. And the other impact, I think, that to bring back home to the community, kind of what the Major General's talking about, is the families. You know, what about that wife and the kids that can't go to baseball practice, and the wife who has to make peanut butter and jelly sandwiches for all the kids and put all the kids in bed, and she's at home dealing with all the, because life goes on. And it's I think for the families back at home, the community involvement and support is just as important. Just as important.
Yeah, I think this is a great point to turn it over to you, Chuck, if we could for a moment. If you could talk a little bit about the psychological implications and some of what you've heard both on the helpline and from your own experience.
Well, first of all, there's a tremendous correlation between the trauma that you're seeing, in other words, the initial going in and not trying to do anything more than save a person's life. I think what we're seeing from a mental health perspective with the reconstitution, and those of you that were involved at Fort Dix with the reconstitution, the initial screening was a 5 or 7 minute, and in essence was a triage to just check in, see how the person is doing, but more importantly saying, look, you don't know what's going to happen when you get back home. We don't know what's going to happen when we get back home, but we want to let you know that people are here to be there for you. So when as you doctors were talking about the medical, basically that's what you're doing. We're here for you. We don't know how this is all going to shake out. And then gradually, as we just finished up the 60-day, now what we're starting to do after the 60-day, now we're getting the calls. In the last month and a half, we got 40-something calls that were not there 2 or 3 months ago. Why? Because now the things that are happening, people thought they'd get back, and over time things would get better, and they're finding out they're not getting better. Now let's talk basically one of the phenomena between the Vietnam era and the current era. When I went to Vietnam, 99-point-something% of the individuals that went to Vietnam were single. They were not married. The Adjutant General talked about the Guard being deployed, around 50% of the Guards deployed. Well, we know that most of them, if not all of them, are at least older, and they're married and they have families. So now we have secondary trauma, or we've got vicarious trauma. Not only is the individual in a war zone worrying about his day-to-day operation, but he's got a family back at home that he's worrying about, and the kids are still going to school, and they're not doing well, and the wife or the husband's trying to make it and make things going on. So what we're finding is, if I had to nail down the biggest thing that we're seeing in all of the calls is the family issues that are on the forefront. And so my challenge is going to be to us as a team is to really start looking at ways that we can meet the needs of the families that are back home. Because I think we do a good job, but I think we can even do more so to understand this vicarious trauma that's happening within the family structure. We had a call a year ago from a parent, a 5-year-old, told his kindergarten teacher that his dad was deployed and he missed him so much that he wanted to run in front of a bus and kill himself. 5 years old. So is it real? Absolutely. I have a 4-year-old grandson, and I know how they connect and how they think, and they can't always communicate everything, but they have the ability to feel and think and process. So from a family perspective, it's something that I think we really need to take a very, very strong look at. The other thing is the marriage issues. We're seeing more divorces and separations. Some of that is because the person at home just can't deal with it anymore. We deploy once, maybe, but now we're deploying 2 and 3 and 4 and 5 times. My son deployed. He's a school teacher in South Brunswick High School. And he was deployed as part of the 50th Division, 50th Brigade, when they went to Cuba. And I know what he went through, and I know what I went through as a dad being concerned about him going to Cuba. Now, Cuba wasn't a hot spot, but I was still concerned about him. So when we think about this whole effort in the war, not only are we dealing with all these medical issues, but we're dealing with a lot of mental health issues, but we're also dealing with a lot of family issues, and we need to really take a good look at that.
Thank you.
Chuck, when I went to Vietnam, we were all draftees. I was a volunteer.
Right.
And we didn't receive a whole lot of welcome home when we came home. But I think the people that I had the most trouble was with family, because I went back to Vietnam. And I went back to Vietnam, and I went to Desert Storm, And they knew it was volunteering, and they thought that was abdicating my responsibilities as a father and husband. In fact, when I went to Desert Storm, my wife accused me of bucking for promotion. I told her I was too old to get promoted, but she didn't believe me. So I know you face a lot of hostility coming back from Vietnam, but times have changed, and this is an all-volunteer force.
That is correct.
So we put things in place to help those coming back.
That is great. Yeah, that is absolutely, we're doing, New Jersey, most of you are not aware, New Jersey is the only state that has the kind of program with the combination of UMDNJ and the Department of Military and Veterans Affairs. And quite honestly, as a side note, we should be very, very proud of what we're doing in Jersey. We get calls, believe it or not, every week from states, and they ask the question. Now, I live in Pennsylvania. My own state's asking me, why are we doing anything in Pennsylvania? I can't answer that question. I said, call the governor's office. I can't answer that. So we are doing so much for the families, but can we do more? Yes, we can. And that's not a knock on anybody. That's the reality of it, is that it's coming to the forefront that we have these problems that we need to deal with. And are there answers? Well, I don't know. We have to take a good look at it.
Thanks.
Thank you, both for Carl and Joe. Any thoughts or comments on why maybe soldiers are still resistant to discussing, the psychological impact, or really for any of the panelists who would like to comment?
So there's a mentality in the military that, it helps us do our job. There's a mentality, especially in the combat branches. I saw it in the infantry. It's to suck it up and drive on, to sort of put the mission first, put your teammates, your fellow soldiers first before you, and then think about yourself later down the line. And it's great that these soldiers put themselves, last. And put their teammates first. It says a lot about them, but at the same time, when they come home, it can be detrimental to them receiving care. And it's not as far-fetched as you think. I myself normally would consider myself, an educated person, but when I was serving in the infantry, I actually broke a bone in my foot and didn't tell anyone for a month because I didn't want to get sent home from Fort Benning for more care. And that type of mentality, unfortunately, can translate into people not saying anything about the way they're feeling. And we see that every day. I go to Fort Dix. I'm going to go actually today and then Saturday and Sunday to see more soldiers. And once again, you see them joking and talking and acting completely normal, not admitting to their friends, not admitting to their closest friends who've served with them overseas that there's something wrong. But when you actually talk with them and try and get it out of them and you open the floodgates, you see that there are these issues. And so one of the most important things is to build a supportive environment, and that's why I think what Master Sergeant Arnold is doing and what Joe's doing is really important, because it builds that supportive environment and allows them to open up and get the help that they need.
Just one other thing. I agree with Carl, everything he said, but these soldiers, airmen coming back, they're not ready yet. That's the reason why they're not getting the help. I've said, before in other venues, we better be ready in the next 5 to 10 years for this new generation of veterans coming back with the problems they're going to be facing. You think the VA system is overwhelmed right now? They better maintain the levels that they have of personnel on hand to take care of these new veterans. There's a lot of them, and it takes a while for these problems to manifest, and fester.